Okay.
All right.
Ready to?
Three because of the thing.
Ready for part 2 for our SBHCI structure live case. Really interesting. All the faculty shown here. Myself, Dr. Kini, then Sahil Khera, our Director of Structural Intervention at Sinai, Dr. Gilbert Tang. He is the Director of Surgical Structural Intervention Program for the system. Then we have Dr. Stamateos Lirakis on the echo. And then we have our cardiac anesthesiologist, Moi Trin. With that note, we are all ready to show this another, like when we said DES are very good, but then we start getting DS restenosis. So same situation, the TAVR is good, but what happens if the TAVR fails? And this is basically the case is, patient has presented with heart failure symptoms. Patient had the TAVR done in January 2016. That time it was a Evolute 29 millimeter and had a complication with the requiring, patient does require permanent pacemaker. Since then, patient has done fine for last about 6 years now, 6.5 years kind, and start having more symptoms. And as a severe degenerative, more as a transvalvular aortic regurgitation, not the paravalvular aortic regurgitation, only little gradient, and we'll show you that both on TE and echo. With that note, maybe we can just directly show the echo finding.
Yes.
This is actually we had before, but I think let's go to the live echo.
Yes, good morning or good afternoon, I guess.
Little louder.
Yeah. You hear me now?
Yeah.
Yes. So this is a 4-chamber view, mid-esophageal with showing normal LV function, normal RV function, lot of calcification, mitral annular calcification, mild to moderate mitral regurgitation. There is also some moderate tricuspid regurgitation. Not evidence of significant pulmonary hypertension. This is mid-esophageal long axis view where you see the evolute valve. This is a zoom-in image of the with X-plane of the short axis and long axis view of the aortic prosthesis. And this is with color. And you can appreciate the severe valvular aortic regurgitation. Also, there is minimal paravalvular. Vena contracta of this valvular AI is 8 millimeters, which signifies severe aortic regurgitation.
Okay, land.
Normal LV function in the deep gastric imaging with no evidence of pericardial effusion. And this is a zoom image of the deep gastric view of the aortic prosthesis, as you can see here. And you can appreciate the 2 jets, one paravalvular, and the significant valvular regurgitation that appears as paravalvular if you don't pay attention. And we have the X-plane that makes things easier. This is the X-plane on the paravalvular jet, which shows in the 90 degrees image that is really paravalvular. And this is the X-plane on the valvular. You can appreciate that it comes from the center of the valve and it's not paravalvular. So pressure half time of this jet is 210, signifying severe valvular regurgitation. And as Dr. Sarma said, the velocity is, the mean gradient is 7, peak gradient of 15 through the valvular prosthesis. Thank you.
Fantastic. So now, if we can show the aortogram, how do you see the regurgitation on the aortogram? Yeah. They are done. This is the valve. You have it. They have good 2 aortogram pictures. Yeah.
Right, okay, here.
Yeah. See, very horizontal. No, but catheter is too far.
Yeah. Well,
Yeah, another one. Yeah, coronaries are there, very short.
Yeah.
But that's it. We knew by echo severe, and these are the coronaries, because that will be the issue when you do a valve in valve, whether surgical or TAVR, about the which valve to use, and there is incidence of coronary obstruction, as you know. So this is the kind, we have done about handful, maybe 7, 8 of TAVR and TAVR. We actually had done quite a number of cases with the TAVR in surgical valve. 3 cases we had done surgical valve, TAVR, and then failed TAVR. So it means 3 valves. So rare cases, but key is this disease will continue. More we go past, now knowing that most of the TAVR were done in 2014, 15 and 16, numbers which will degenerate, even if the degeneration at 10 years is about 10% or 5 to 8 to 10%, which will patient will start coming back. Usually patients with the renal disease are more troublesome. In this particular case here, the whole question is you're trying to put a valve and you have a coronary obstruction with the no matter what type of valve we use. I'll ask both Sahil and Gilbert make a comment on that. Is there one valve is better than other valve? Whether you should go back to the same evolute or sapien will be better to create less chance for coronary obstruction. Yep.
Okay, thank you, Dr. Sharma. So, couple of points here. One, obviously, the depth of your prior TAVI valve determines a lot for future TAV and TAV. Second is choice of evolute versus sapien. If there is no risk of coronary obstruction, you would go with the hemodynamic benefits of evolute. But if you think there's a high risk for coronary obstruction, my choice would be to go with the sapien.
Okay, Gilbert?
Yeah, I mean, we have seen different failure mechanism. This one is transvalvular AR, so you're less concerned about pinning the leaflet and causing the obstruction versus if this was a stenosis case. So I think the mechanism is also important, and as Sihu mentioned, the implant depth, commissure orientation, is becoming more and more important. This case you see in the presentation that we prepared, that actually, thankfully, the CT showed good commissure orientation, commissure alignment. So that's why we're able to engage the left main relatively easily.
Yeah, and therefore, in this kind of case, Anu will do the wire protection?
Yeah.
Yeah. So not necessarily the stent?
No need for stent. I think just wire protection would be enough. And you see there, I think this is what the discussion always is reaccess after having placed TAVR valve. Yeah.
Okay, any questions by the faculty? Yeah.
Pedro Villabanca here from Henry Ford.
Yes.
Good seeing you guys. Quick question. I think this is for the audience too. Now when we do TAVR in TAVR, we have to start thinking about the neo-skirt, right?
Yes.
So did you get a CT on this guy just to get some reference of the new sinuses and STJ just for the audience? Because
beautiful. No, of course, that's the minimum. We have, go back to the slides, please. So we are going back to, you're absolutely correct that you need to have a CT to really plan these cases. So this is the original, CTA of the LV annulus and LVOT. So this here looks okay.
Yeah, so this is the inflow of the 29 evolute. You can see it's not 29. It conforms the anatomy. The LVOT hasn't quite dilated despite the AR. Next slide. So we routinely look at where the neo-skirt base is. This is the base where the evolute it's at where the leaflet starts, right? So you can see this the dimensions around 400 in terms of area. You can see the calcification of the native leaflet. Then you move up to the commissure level. This is where the top of the evolute leaflets will sit at the commissure, and you can see that the frame is around 400. So it's pretty circular there. So you can see also there's room around that frame for potential expansion. Next slide. So this is the money shot. So what we look at is essentially where the native annulus might have been and where the depth of the evolute implant is. And then you just basically do some calculations on where the neo-skirt would be. You can see the 25 millimeter yellow arrows. That's where the top of the evolute leaflets would be. So if you put the sapien free very high, you could go all the way up there. So that would not be ideal in this situation. You can see where the left main is, where the sinus is. And you can see the 14, that's the base. So that's the bare minimum that you'll be clearing. Next slide. So this is what we talk about a commissure alignment, right? So if you want to consider basilica or shortcut or reaccess, you will want to have commissure alignment. And thankfully, this patient, you can see here the three blue arrows. Those are the evolute commissures. You can see the left and the right. They're not 120 degrees apart, so the right may be at risk too, but you have to pick your battle about what to protect. And you can see the next slide. So this is what, we look at the VTC, right? The VTSTJ that you talk about. So if you use a 23 valve, you're not going to expanding as much, so you might have better clearance. But because you're using a 26, especially we're putting the valve in the inflow. So there have been cases that you undersize the valve, you can embolize the valve in valve. So because of that, we're going to upsize this. It's not going to foreshorten as much. Because of these anatomy, we're going to need to at least protect one corner. Next slide.
Now, distance, what is ideal? 4 millimeter? What we are looking for?
Well, I mean, they actually say 2. Yeah. So there's a little bit different in terms of TAVR and TAVR, because 2 is what we consider now. So next slide.
All right, so it's a 2.6. Now, this is where it is now.
Yeah, this is horizontal. Yeah, the next slide. I think we saw that in the aortogram already. And so here we want to talk about access and
Redo TAV and TAV from the same site can be challenging. It's usually a very fibrotic site. This patient has a bunch of tortuosity and just the acute angle. Otherwise, fairly non-calcified.
Yep.
and you can see the
one
horn, yeah.
bend in the aorta. The patient underwent an evolute back in 2016 without any issues. So hopefully the SAPIEN with the flex system, we should be okay.
Okay. And so now.
Yeah, just a couple of points here. I want to point out people, where do you put this valve? So I think this is a paper from jack intervention done by the Vancouver group on the bench. So you can see you can potentially put it in different parts of the evolute depending on what the mechanism is. And that depends on what you look at. Next slide. So with this particular case, what we think of is because the left main concern, we're going to put the top of the SAPIEN right underneath the left main orifice. If you look at our aortogram, basically no higher than 2 full diamonds. So you have to account for that when you deploy, because with the AR, all you care about is restoring competency, right? You don't really care about what the native leaflets are doing because there's no gradient. If it's aortic stenosis, that's a different story. You have to pin the evolute leaflet a little bit so you don't end up having a functional stenosis. So thankfully, I think we could be okay here. We're going to do the wire protection just in case.
Okay. So therefore, just to sum up, this is a 90-year-old patient with worsening his symptoms with the TAVR in January 2015. And rest are shown here. So plan here is now the TAVR in TAVR using 26 millimeter Edward SAPIEN 3 Ultra via right perc approach for the degenerated 29 millimeter Evolute Pro TAVR and central device.
It's very tortuous.
Because tortuosity was not used, and we'll use a wire left main protection, not necessarily the stent. Many times when we do a protection, we put a stent parked distally, but here chances are less, so we're just doing a wire protection in case if necessary, then you can advance the stent. But yes, many times when we do a preempting protection, we basically advance the stent into the vessel, LAD or circumflex, and if there's obstruction, then you pull back and deploy it. But in this case, decision was made that just the wiring is good enough.
Yeah, the other point is that this is not native like bulky calcium, right? These are just prosthetic leaflets, and you have big sinuses, so you should be able to re-advance the coronary stent if you absolutely need to. I think that's the main difference versus a native leaflet obstruction.
One question I want to ask Dr. Kinney as well. She's done a lot of work on coronary reaccess. Use of guide liner in evolute cases when you do wire protection. What is her thought, just for completion purposes?
So I think here you can see that the guide, you want to make sure the guide has gone through the diamond and it's in the sinus, and you're able to really engage into the coronary, which we are able to do that here. So in situation, that is why I think I'm going to show you the animation where we have a bird's eye view, where it's not the diamond, then you have a strut in front of the left main or so. To get access, you usually can leave the guide in the valve just at the ostium, then you wire the coronary, free wire, then you get your guide liner in. So those are the situations. So I think another point we also want to make is how to engage this valve. So you see here, the FL guide has nicely gone through one of the diamond, and it is sitting in the sinus, and we were able to wire easily.
FL3O, always use a smaller guide because of the constraint. Yeah.
Okay. So now how do we engage, how do we cross this prosthetic valve? During our many of the live cases, if you are a native valve, we usually use AR, which is AR2 for a regular aorta. If it's dilated, maybe AR1. But then this is a fluorosave. You can see here when you are doing the TAVR valve crossing, use a J-tipped wire and a pigtail. You make sure you are inside the valve. You see that? Then get your pigtail, and you're just there. It will fall very easily. Okay. You should not be too aggressive to push it. You see, this is just, we are trying to show it over and over again.
All right, so once everybody is ready, we are ready to, we are in the ventricle already, changing to a safari.
Yes.
Gilbert.
Yep.
Yes.
Gilbert.
Any questions?
Here, I want to ask a question to you, because you selected a SAPIEN valve here. We're talking about two different things here. One thing is, this patient is 90 years old. She doesn't have coronary disease, so the likelihood you're going to have to go back in those coronaries is very low, right?
Yes.
So could you elaborate more on this discussion of why choosing SAPIEN? I myself would be comfortable doing an evolute inside that evolute. You have a commissure aligned. You can align your commissure again. Again, I wouldn't be very concerned having a re-access to those coronaries. So can you elaborate on the rationale of why sapien and not evolute here?
Yeah, we went over this
Go and
presentation
over with that,
very
yeah.
quickly, but actually the right coronary is actually very close to one of the commissural posts.
Yeah.
So with the evolute, you're going to be basically create a higher neoskirt just
increase
because
the
it's a
volume.
taller valve. So our concern is that, there might not be sufficient sinus flow around the sinotubular junction, and there's a right dominant circulation. So that's the concern. But you're right. If there's no concern about coronary obstruction, then I think either valve, and Sahil mentioned that as well, in terms of hemodynamics, certainly would be potentially beneficial. And we know that most of the second time when you put a second valve in, it's going to be constrained somewhat one way or the other, even with the sapien that we're going to put in right now.
Okay.
I have
So
another
now-
question. Why are you using TE?
Go.
What information does the TE provide to you that you really, because this patient is 90 years old, right? So are you doing her in general anesthesia, and what kind of information you're expecting to get from the TE?
Yeah, well, I mean, we do it for safety here because there's a live case going on, but also want to look at the mechanism again, and also look at in terms of other characteristics such as paravalvular leak, gradient, transvalvular leak. So I thought that yes, of course, you can do transthoracic echo. This is a fluoro guided procedure, as you see here. It's not really echo guided, but we have excellent imagers here in our institution. So we prefer to do this. Any valve in would typically prefer TE unless the patient cannot tolerate it, just because we have better assessment. And in fact, there's some controversies now saying that maybe TTE in TAVR might be undercalling PVL. Actually, we've seen a couple of cases that were done outside our institution that was saying to be mild PVL, but actually when we interrogate with TE, it's actually more. So I think with this in mind, with this patient, given that we're showing you this case, we would prefer TEE. So, but you're right, we might just do TTE had we just been in other circumstances.
Okay, so we have loaded the valve now.
Yeah,
Go.
we're going forward, okay?
So you can see the
going full
very
flex.
very
Yeah.
angulated aorta.
Full flex.
You can see that bend that we are.
Yeah, we're going to go to
navigating.
implant angle now.
And you have picked the guide catheter may move with all this process. Yeah.
Yep.
Good. Okay.
Yep.
Okay, good.
Just the wire.
can
Gilbert,
see
I want
now.
you to hold the guide.
Yeah, 1 second. Let me just mag it now. The wire is inverted, so I don't know the way to move the wire position.
Will be okay.
Good.
Okay, I'm going to mag in just so that we can see, everyone can see properly.
I
because
think we are
to,
good there, see?
We need to count the number of diamonds. So
Take a cine.
Not yet,
no,
wait.
you don't need to. Let's see. Okay, I think we're a little too high, right? So
Yeah, I think we're going
Oh,
in,
no.
going in.
the outflow has to be no higher
Yeah.
than 2 diamonds. Yeah, right around there.
Yeah.
Let's take
No
one
higher
cine.
than that. Yeah.
You're good?
You have
Cine.
your eye. You can actually load the valve pretty low.
Inject.
It's too high.
That's it.
Okay, go low, come lower.
Too high?
Yeah, too
We're
high.
going in?
Going in,
There.
going a little bit.
That's it.
Going a little
See
bit.
the loosen
Yeah,
one.
no, it's not. It's we don't want the high to have to pin the
Go to your
leaflet.
speed.
Yeah.
Not yet.
Check
By the
once
way,
again.
you're good?
Your eye. You shouldn't be
Okay.
worried about not the old leaflets.
Yeah.
We are not worried. Yeah. Only thing was the RCA we are more concerned. Yeah.
Yeah.
Let's go to. We are going to check.
180.
I'm doing the injection. Off.
Yeah, that
Okay,
looks
off,
good. That looks
off.
great.
Okay, good.
Yeah.
So we always
Okay.
check it before deploying. A lot of people adjust while they're doing it, but we
Okay.
always do that.
1 second, guys.
So we are ready here.
Beam with the
Okay.
guy.
Pull the guide back just a little bit. Good.
Yeah.
Okay.
Okay. 180.
Yeah.
I'm going up now. Okay, going up.
Go. All the way.
Perfect.
Very nice.
Okay, I'm 7.
Great. Excellent.
Keep pacing.
Don't do
keep
anything.
pacing.
Continue pacing. Okay, off pacer.
Off pacer.
Oh,
Resuscitate. Excellent.
Okay.
let's take this system out. We're not going to.
Okay. No EKG changes.
Yeah.
Good.
You're showing the EKG. Good.
Excellent. Let's check.
Okay,
some
let's take a
coronary
quick picture of
Yeah.
the coronaries.
Yep.
And then we'll do the echo. Yeah. Oh, echo is being seen anyway. Yeah. Good.
Yeah.
Cine.
Okay.
flow. Beautiful.
Okay,
Right.
good. No obstruction.
And
We're
there's
good.
no AI also.
No
you know.
AI.
Yeah,
of
no
course.
AI.
No AI.
Okay. So,
So
show
we're
the
taking out the
echo now.
wire.
What you see in
So
the
you
echo.
can see this is a very conservative placement, right? You're right. We could go a little higher, But we're still learning about these procedures. As you know, there are not that many been done, even around the world with some of the published registries. And remember, this mechanism is AR, not AS. So AS obviously will be a very different positioning in terms of the needing to pin the evolute leaflets so that you don't have the functional stenosis.
No,
The other
yeah,
thing, Gilbert,
no, yeah, excuse me. Yeah,
you point
sorry.
out the mechanism. I think when you have failure with central AI
Yeah.
and you have risk of obstruction, if you put the second valve, you can actually go lower and have no interaction with the old leaflets because you're not going to have the second valve effect of a stenosis.
Correct.
So I
That's
think
right.
if you think so, I think in this case, if you would have been at risk, you could actually be lower and
Yeah.
prevent the possible.
But I thought
Yeah.
we went quite low here.
Yeah,
right?
no, we're fine. So
Yeah.
that's interesting.
Yeah.
So you mentioned that there's some theory also. I think the Vancouver group again shows some of this bench data. So in terms of the leaflet overhang from the evolute leaflet, that sometimes if it's deep, you might actually impact the sapient function. Again, we don't have any clinical data or a lot of clinical data on that, but just based on bench testing. So we're still learning about this. I don't think we know a lot yet. So, but certainly we're here to address this patient's AI, and there's no AI now.
But show the fluoro again. Go back to fluoro, and then we'll go back to echo to end up. And before we go animation, see this now. no, don't go
sorry.
to next. Yeah, we wanted to show this here. So we're quite. We adjusted after that. So we definitely were.
And it's very nice that there's no parallax on the sapient valve
Yeah.
versus the evolute.
Yeah.
Because sometimes with the system, with the tortuosity, you might actually be hard to predict how it goes. But it was very stable on
Yeah,
the
see, initially we were this, then we advanced, we went further down. See that? So as point you made that yes, we want to be, but clearly you don't want too much of the evolute leaflet hanging up, which can give trouble. So with that note, we had done the aortogram. You can see here, which looks very good. Coronary access is fine. You see here, no AI, no para or central. And now we can just complete this with the echo. Bring the echo on the center. Yeah, good. Tell us what do you see, Stam?
So basically, it's minimal central. I don't know if you still have a catheter or the catheter is out. So you can appreciate here minimal central and minimal PVL that was there before the procedure. So overall, great result. Yeah. This is a deep gastric image of the aortic prosthesis, the new TAVI.
Okay, that's right. Yeah. Okay. So now any other specific point while coronary engagement, now this patient comes back. The coronary engagement will be even further tougher, although may not be, right? The valve is leaflets are just below that. Maybe we can just show the another 3D animations or animations which have been created for engagement. You know, we have paper about 3 years ago with all of us studied multiple post TAVR angiograms and which catheter, what to use, sapien versus evolute, various types, and we really went quite a bit on a detail in the JACC paper, which actually have been quoted quite well in many of those publications. And this is now has improved further, Dr. Keeney, with the TAVR cathode, which is again available. And I think the overall with the sapien is a less of an issue. Sometimes we do have trouble, but 95% is no trouble. So trouble happens with the evolute here.
Yeah. So again, this is free to download. This is the app. You can see that very easy. Depending on we have just discussed the FDA approved valves here. So if you go, you have discussion of the each valve and the anatomy. Why is it hard to engage? So earlier when we were placing this, when it first came on, we were never used to do this alignment and all these things, but now commissural alignment is a big thing. So we want to make sure when we place the valve that there is a commissural alignment based on that. So like our any other apps, we always have a brief description and about each valve in this app. So this is the 3D which I wanted to show you exactly how we are going to engage. This is what Sahil was asking me how. So this is the bird's eye view. Remember what I was trying to tell you. Suppose you have your commissural post right in front. then you have to move it. That's why the 3D animation is very important. You have to move it in such a way that you find a diamond, and now you see that the catheter is just sitting in front of the diamond. From there you can wire and get into the coronary, and of course you can get the balloon down, and then you see here, this is how you will get your Godzilla or a guideliner extension get into the left main. So by doing this, we have done complex cases like we have shown. We have even done rotational atherectomy through this because with the 6 French you can do 1.25. So we have done even rotational atherectomy through that. So otherwise, this is the way you would do it. And very important, you see that you do it under fluoro and remove your catheter under fluoro gently. And engaging, like I showed you, is you always use your J wire, get into the cavity of the valve, and then only you try to engage. This is where we are. Now we have the same thing also description for the coronary. Now, other thing is, what is a challenge? During the live symposium that we just finished, we did show 2 cases. One was evolute valve, other one was a sapien valve, engaging the coronaries and doing PCI after TAVR in patients who are symptomatic. This is this challenge we all interventionalists are going to face, since we are doing the TAVR in low risk patients. They may have non-obstructive coronaries, but 7 years, 8 years down the road, they can present with ACS or progression of disease. So we got to be proficient and to understand how we can handle the engage these coronaries in that time. So when we were doing the live case, it was a sapien valve. Same, what can happen is, many times you have the valve, you have a big sinus, we are not going through the valve and engaging into the coronary. Instead, we are going behind. So guide support, guide engagement, movement of the guide could be very difficult. Especially that case was a rock of calcium and nothing could move. Like we showed in our live case today, we had to do all 3 modalities, which was a laser, we had to do rota, as well as IVL. So in that kind of situation, I think it could be hard, it could be tough, but it is not that it's not doable. But I think good knowledge and understanding this kind of how to engage these coronaries is very important. Going back to the point, since you have this metal cage, you see that how aorta is. Now you have a metal cage, so your guide will be smaller. So remember that one simple point. So before TAVR, if you did 4O, JL4O and regular JR, you may have to go FL3O or something. So here we did use an FL 3.5 just because it's a horizontal route and engagement was easier. So always the key point is that use a smaller guide to engage, because now you have this cage that is not allowing your movement of the catheter like it would happen in aorta, which is very elastic, pliable, and you have a good guide support. That's I think important point we have to
Yep,
mention.
superb. And as we said that we'll finish in time. So we got 1 more minute and really ask any question, any feedback to our, our panelists and moderators there. We are ready to answer, the whole team here from the Cath Lab room 6.
It was a great case. I'm curious, what's your approach? And given these cases that you're showing, I tend to explain my patients. I usually, by fixing the coronaries, you're not going to leave more. Actually, there's no data, but I tend to fix them before because later is more challenging. What are you doing? Meaning, are you doing that's my justification to do PCIs before TAVR. It's less challenging if you have calcified vessels.
Yeah, I think very good point. Yeah, very good point. And I know that this has been put to the task with a complete TAVR trial, which is looking into that, whether you should fix it in non-left main, should you fix it, or just and then TAVR, or you just do a TAVR only. But I think what you do, that's what we do. If there is a significant 90, 80, 90% calcific lesion in the proximal vessel, we'll intervene first, bring back patient for TAVR after 1 month. Very rarely we do it at the same time, but usually give 1 month gap, PCI followed by TAVR.
Only for significant proximal vessel disease.
Yep.
Yeah.
Okay, if Fernanda?
Hi, I'm Fernanda here from Sao Paulo.
What really caught my attention was that in the first case, you used an evolute, even though there was a very horizontal aorta, and the prosthesis was really deep into the ventricle, what ended up avoiding the coronary obstruction in this case. Do you think it might have been better if you had used the balloon expandable valve in the first case? Would it be easier now?
Well, I think the issue, at the time was that there was a lot of annular calcium, so we were about annular rupture with the sizing.
Yeah.
So that's why we, decided on a self-expanding valve to be safer.
Yep.
You actually saw the CT earlier. There was a lot of calcium right at near the inflow of the valve. So.
90.
Huh?
90.
No.
Thank
Gilbert.
you, Sunny and Kini. It was a wonderful case. You gave us a lot of message and hope to see you next year again.
Beautiful.
You're the best.
All right. Thank you.
Thank you. Thank you.
Okay, thanks everyone.
Thank you. Great work.